Good afternoon, everyone. Welcome to this webinar entitled Primary Care Point of Care Ultrasound, Why it is Needed and Common Questions about Billing and Credentialing, presented by Dr. Paul Bornemann. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to understand why point-of-care ultrasound is needed in primary care, know the current state of point-of-care ultrasound training and use in primary care, discuss several high-yield applications for point-of-care ultrasound in primary care, and answer common questions about billing and credentialing for point-of-care ultrasound in primary care. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Paul Bornemann and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Paul Bornemann.
Okay, thank you, Darcy, for that introduction, and good afternoon, everyone. As Darcy said, I am Paul Bornemann, and I'm currently the program director for the family medicine residency at the University of South Carolina. But I've had an interest in point-of-care ultrasound that dates back to my time as an active-duty Army physician. Back in 2010, I did a active-duty combat deployment with the 10th Mountain Division as their battalion surgeon, and I afterwards developed some interest in point-of-care ultrasound and some of the applications that could be used. I learned from some of my ER colleagues at the time, and I really do want to stop and thank our ER colleagues who really have blazed the trail with point-of-care ultrasound for us and made it a lot easier for us in primary care to adopt it. But I learned of some of the applications that the ER guys were using it for, and I saw how that would be valuable for an Army physician in the operational or combat environment or the otherwise austere environment. So I wanted to learn as much as I could, and as I learned more and more, I saw that the applications really would be useful even outside of that, just for everybody in everyday primary care, or almost anybody in any medical specialty. And from that point on, I developed an interest in learning more ways that we can incorporate it into primary care, including curriculum for graduate medical education. I just want to start by saying that I do have no disclosures to discuss. So why ultrasound in primary care? I think I like to start off by making the argument about the system that we have right now. As most of you are aware, I'm pretty sure that healthcare in the United States is really expensive. We spend more than any other country by far. We spend 17% of our gross domestic product, which is more than twice as much than the next industrialized country. And for that, what do we get? Well, we actually have some of the worst outcomes of all the other industrialized countries. We have the lowest life expectancy, we have one of the highest infant mortality rates, and also the highest chronic disease burden. And if you look at this graph on the right side of the slide here, you see on the left side is the amount of money spent per capita on healthcare, and on the right side is the life expectancy. You can see the United States spends far more and has a lower life expectancy. And why is this? And there's probably multiple reasons, but I'd make the argument that one of them is that we do spend a lot more on expensive diagnostic testing than any other country. Additionally, a lot of our patients in the United States don't have ready access to healthcare through low-cost means like primary care. 12% right now of adults in the United States do not have medical insurance. So what do when they end up getting sick? Is instead of getting preventative care or low-cost treatment of primary care, they end up going to the emergency room or accessing the healthcare system through other expensive portals, such as through the hospital or the emergency room. As far as diagnostic testing, if you look in the United States, 1 in every 10 people has had an MRI. That's everybody in the US. And 1 in every 4 has had a CAT scan. And that's more than twice as much as the average of other industrialized countries. So if you look at that, that's definitely something that could potentially be contributing to why we're spending so much on healthcare. So ultrasound has been shown in a lot of different circumstances to be able to help decrease the use of expensive diagnostic tests such as CT and MRI. There's been several studies, one of them in 2014, that showed that point-of-care ultrasound in the emergency room could decrease the use of CT scan for diagnosis of kidney stones by 50%. There's another study in 2010 that looked at, in a healthcare system, the usage of MRI for musculoskeletal applications. And they found that of 50% of those MRIs that were ordered could have had an ultrasound ordered first instead of the MRI, and potentially would have saved the healthcare system billions of dollars over several years if ultrasound was used first when it could feasibly be substituted for MRI. And then also for procedural guidance, central line guidance, thoracentesis, arthrocentesis, almost any procedure where you are putting a needle into a patient, there's data showing that if you use ultrasound for guidance, you decrease complications and you have better outcomes. And I encourage you all to go to the ultrasoundfirst.org webpage, which is sponsored by the AIUM, and there's lots of different articles about applications for ultrasound where it could be used first instead of other expensive diagnostic tests. So point-of-care ultrasound, the way I define it, point-of-care ultrasound is an ultrasound that's done by the physician or the provider taking care of the patient at the bedside. It's usually a limited protocol, which is asking a specific question, very often a yes/no question, and it will affect the way you're managing that patient at the time that you're seeing them, or it can be used to guide procedural, guided procedure as we were just discussing. And there's more and more evidence mounting that point-of-care ultrasound applications can be performed effectively by non-specialist physicians who've had limited training in these specific protocols. And again, a lot of this comes from the emergency medicine and critical care literature, but a lot of it can be, is starting to be shown to be effective also in primary care physicians' hands, but also it could be extrapolated that generalist physicians such as primary care could also pick up these applications. And again, lots of applications, AAA screening, assessment for deep venous thrombosis, different applications of cardiac ultrasound, and the evidence in family medicine is mounting. We did a study in 2015, and again, this was in a military residency program, family medicine residency program, where we actually introduced point-of-care ultrasound to the staff and residents, and we gave them education, training on how to use it for different applications. And then we did a survey at the end to get their perceptions of it, just to see if this was really a feasible thing in primary care outpatient setting. And the perceptions were positive overall. The physicians and residents were very enthusiastic about the ultrasound use. They felt it was easy enough to learn, that it could be practical in day-to-day patient care. They felt that it was likely to improve patient care, and they did not feel that it was overly time burdensome, that it would not be able to be used on a practical basis. So what is the current state of use of ultrasound in primary care and family medicine specifically? There's a study that comes out from the AAFP every year, the American Academy of Family Physicians, and most recently, the survey has shown that only 6% of family physicians currently report using ultrasound for non-obstetrical applications, which is really not much. We did a study in 2015 where we sent out a survey to family medicine residency programs to see who was currently training the residents to use point-of-care ultrasound. And at that time, we found that only 2% of programs had any type of formal point-of-care ultrasound training. You can see that's the blue sliver on the pie chart here. But over half the programs were either planning on implementing in the next year or were interested in learning how to implement an ultrasound curriculum. So that goes to show the amount of interest that is starting to come down the pipeline for point-of-care ultrasound in primary care. So I think if you take that into consideration with a few other things, as we talked about, there's growing evidence that point-of-care ultrasound protocols can improve patient care, can improve outcomes during procedures. The other thing is that there's over 20 medical schools now that have point-of-care ultrasound curricula integrated into their undergraduate training. University of South Carolina was one of the first medical schools back in, I think it was 2006 when we first started training our students here. But now over 20 schools have claimed to have some sort of point-of-care ultrasound curriculum. And that seems to be going up every year. I check back and it seems like that number increases by at least a few schools every year. So there's a lot of interest. And these students, when they get out of medical school, you know, those who are going into primary care professions, they continue to have that interest. They want to continue to use those ultrasound skills that they learned in medical school. And if you throw on top of that the fact that the ultrasound devices are becoming smaller and less expensive, almost exponentially it seems, kind of going the same route as the smartphone. Every year it seems like there's a better device out that's less expensive and can do more. Really, we're going to have a ubiquitous presence of ultrasound devices in the near future, and we're going to have lots of physicians who learn how to use them in medical school. So I think the analogy of the tidal wave that's coming at us really does make sense in this situation. Point-of-care ultrasound is coming to primary care, and I think at the point that we're at now, we can decide whether we're going to be early adopters or whether we're going to lag behind and have to learn this later on. So as far as the American Academy of Family Physicians, they're starting to show some interest on a national level as well. The last year at the 2016 Congress of Delegates, there was a resolution that was passed, and this came actually out of the student branch of the AAFP. But this resolution that was passed, as I said, states that the AAFP recommends now that all family medicine residency programs have an integrated point-of-care ultrasound curriculum in their residency curriculum. And it also recommended that the AAFP provide more point-of-care ultrasound CME for the family physician members. Now, this is a non-binding resolution for residency programs, but it did produce enough interest that the AAFP has sponsored a point-of-care ultrasound curriculum guideline, which is now in the final stages of approval, and this should be available on the AAFP webpage in the next few months. Also, there's a new point-of-care ultrasound member interest group for members of the AAFP. We started this just over a year ago, and we have over 300 members now who are interested, and I encourage anyone who's an AAFP member and is interested in joining to go to the link here and look into our member interest group. So a lot of times the question comes up, what are the most common applications for ultrasound in primary care? And you know, this is such a hard question to answer because in family medicine, in primary care, the scope of patients that we see is so broad that really we can use ultrasound for almost any point-of-care application that's out there. And again, a lot of the applications that have been used in emergency medicine and critical care, they all make sense for primary care as well. But I think there's also there's some exciting aspect of this, that in primary care, since this is still relatively new to our field, there are potential uses that have not even been thought of yet. So that leaves us a lot of room to be innovative and to be creative and to do research and come up with new applications in ways that we can use ultrasound for the chronic care of patients and diseases and for prevention, as well as the other applications where it's being used in emergency medicine. So I'd like to illustrate some of the examples here in just a few interesting cases of some patients and how ultrasound can be helpful in the primary care setting. And I'm not going to go too much into depth about the actual performance of the ultrasound protocols. That would be, for another lecture another day. But I just want to introduce some of the concepts of how this potentially could be useful. So first, we're going to start with our patient, Mr. T. He's a 63-year-old gentleman who has no past medical history, but he's come into the office to see you a few times for just general health maintenance visits, and it's been noted that his blood pressure has kind of been on the borderline of hypertension, about 140/90 on average, sometimes a little higher, sometimes a little lower, but otherwise his physical exam's normal. So your question is then, is this somebody who should be started on blood pressure medication at this point, or is this somebody who you would just continue to watch, maybe give some lifestyle changes recommended? And as we know, the office measured blood pressure is really not very accurate, and this has been recognized and has led to the United States Preventive Services Task Force come out with a recommendation now that in stage 1 hypertension, all patients should have that confirmed with preferably ambulatory blood pressure monitoring, where they wear the monitor for a 24-hour period. Or if that's not available, home measured blood pressures over the course of several days, because again, the clinic measured blood pressure is not that accurate. And part of the reason is the phenomenon of white coat hypertension and masked hypertension. In this graph here from a study in 2014, on the y-axis, you can see the left ventricular mass index, which is a measure of the degree of left ventricular size or hypertrophy. And there's 4 different categories here. There's, on the left, the 2 patient groups that had normal blood pressure on ambulatory blood pressure monitoring, which includes those who had high blood pressure in the office, which would be called white coat hypertension. And you can see that they both have statistically the same degree of cardiac enlargement due to end organ damage from their blood pressure. Now, if you look at the 2 bars on the right side, these are patients who have sustained hypertension, who are, they would have high blood pressure in the clinic and then also on ambulatory blood pressure monitoring. And then there's the patients with what's called masked hypertension, where they actually had normal blood pressures in the clinic, but on ambulatory blood pressure monitoring, they had elevated blood pressures. And you could see that they had just as poor end organ damage outcomes as those who actually had sustained hypertension. It was found that most of these patients who had this masked hypertension in the clinic didn't have completely normal blood pressures, but a lot of them had prehypertensive blood pressures in the range of 120 to just less than 140 systolic. So why would we care who's developing left ventricular hypertrophy? Well, as we know, it's one of these end organ damages that can occur from hypertension, which is really associated with a lot of morbidity and mortality. There is increased risk for sudden cardiac death. There's increased risk for death if a patient has an MI. There's increased risk for stroke, increased risk for heart failure. And also, interestingly, the degree of hypertrophy increases linearly with the left ventricular, the degree of average daily blood pressure. So if you measure out the left ventricular mass index, that correlates linearly with the patient's average systolic blood pressure as measured on 24-hour ambulatory monitoring. And in addition to that, if you treat the patient's hypertension, you can actually decrease their left ventricular mass, and you can decrease their risk of these morbidities and increased mortality. Traditionally, EKG has been used as a screen for LVH, but we've seen that EKG really does have a low sensitivity. It's only about 50% sensitive when compared to echo. So for the patient that we discussed above, or maybe any patient who presents with prehypertension or borderline hypertension, there's an exam that can be done relatively easy at the bedside, which is to measure the left ventricular mass index. and this can be done from a relatively easy to obtain parasternal long axis window. There's 3 measurements that are made, and on the bottom of the screen there's a link to a calculator where you can go there and you can plug in these measurements, and you can plug in the patient's height and weight, and if you wanted to do that for this patient you can. I'm not going to do it now for time's sake, but that would give you an estimate of their left ventricular mass index, which again is linearly correlated with their average blood pressure on 24-hour ambulatory monitoring, and also related to their risk for end organ damage, morbidity, and mortality. And so how difficult is this to learn? Well, it's relatively easy. It does require some training. We did a study last year that was just recently published with family medicine residents and medical students, which showed after an introductory training period of 4 hours, and then it looked like it would take about 50 supervised scans with feedback, and at that point it was extrapolated that they would be within 10% error of an expert sonographer. So again, this looks like this would be something that potentially could be learned after brief training by novices or generalists. And the way I would suggest using this would be you would have, again, the patient with prehypertension or borderline hypertension, or maybe if you're not sure if they're well controlled, and you could do this measurement of LVI at the bedside. And if you go down the left side of the screen here, those with normal left ventricular mass index, you can be reassured that they have normal blood pressure most of the time and that they're not experiencing any end organ damage as far as the terms of left ventricular hypertrophy yet. If, however, they do have elevated left ventricular mass index, then that would suggest that they probably don't have controlled hypertension, even if they are controlled in the office, and that would suggest that you should intensify therapy, and then, you know, it would take approximately about 6 months for their heart to show resolution of the therapy, so possibly in 6 months have them come back and follow this up to repeat their LVMI and see how they're doing. Now, again, this isn't validated yet as a treatment method to improve outcomes. It's something that I think in the future I hope we can look at. But right now, this is you know, one of the suggestions for potential applications that I'd like to propose. Okay, next we have Mrs. M. She's an 89-year-old female with a history of myocardial infarction and systolic heart failure. She's recently been admitted to the hospital, let's say a few times. She was admitted for a CHF exacerbation. She, during this most recent hospitalization, has been diuresed, and she's at the point now where she's clinically euvolemic. She's not having any more dyspnea or orthopnea. On exam, JVD, rails have all resolved. So the question would be then, is there anything else we can do to be sure that we've diuresed her enough that we can decrease her risk of being readmitted? So one potential ultrasound application here would be the use of this, the ultrasound of the IVC to estimate the patient's central venous pressure, which can be a surrogate marker of the patient's overall volume status. And there's good data going back showing that the ultrasound, when you use the width of the ultrasound and the collapse during inspiration, you can use that to determine an estimate of the central venous pressure. Here's an example of what that looks like on ultrasound. You place the transducer in the sagittal plane over the IVC as it enters the right atrium through the liver, and you can see in this middle image you have a small collapsing IVC. This would be somebody with normal central venous pressure, and then on the right side you have somebody with a fat plethoric looking IVC which does not collapse with inspiration. Now, this was looked at in a study in 2008 where they followed patients who were admitted with heart failure, and they retrospectively looked at the groups that were readmitted with those that were not. And they found that most of the clinical findings of volume status were equal in both groups, that both patients diuresed the same amount, their weights changed the same amount, both were diuresed to the point where they didn't have edema and JVD. But the one of the differences that they did find was that the group that was readmitted within 30 days had significantly different findings on their IVC ultrasound. So this was a retrospective study. This hasn't been validated prospectively yet, but in theory, this could potentially be a way to predict which patients were more likely to be readmitted, and it could be used as a tool to guide diuresis during hospitalization, or even more closely in the outpatient setting to try to prevent hospitalization as well, especially after recent hospitalization. So the flow chart here shows that for patients with CHF exacerbation, the recommendation would be to diurese to clinical euvolemia, and then to assess their IVC. And if it's smaller than 2 centimeters, or if it's collapsing more than 50%, then that patient is likely euvolemic and lower risk for readmission, and they can be discharged or followed up as an outpatient. If not, that may be a patient who should be diuresed further till their IVC is starting to show those signs of a lower central venous pressure. And again, this hasn't been prospectively validated yet, but again, this is just a potential mechanism for ultrasound that I propose as being useful in primary care. So next we have Mr. S. He's a 70-year-old man who presents for a well visit. He has a history of smoking, but quit 20 years ago or so. Otherwise, he has a couple other medical problems, hypertension, high cholesterol, which are both well controlled. And what would be your current recommendations for him as far as screening for abdominal aortic aneurysm? So if we look at the USPSTF recommendations, any men between the ages of 65 and 75 who've smoked, it's recommended that they get a one-time screening ultrasound for abdominal aortic aneurysm, and this has been shown to decrease mortality related to aneurysm rupture. But the thing that I find, at least in my practice, is a lot of times when you send a patient for an exam, they may not always get it done for different reasons, whether they, they don't make the appointment or they don't have the time to go get it done. What if we were able to do it while the patient was there for their checkup? What if we could do it at the bedside when we were seeing them for that initial visit in the office? Well, this is an application which has been fairly well validated in the ER literature. There was a systematic review in 2013 that showed 7 different studies comparing ER-performed bedside ultrasound for abdominal aortic aneurysm evaluation after limited training, and they found that the sensitivity and specificity compared to the radiology performed ultrasound was very high and very good. And this has been repeated by a couple studies looking at family doctors doing something similar. This was one study in 2012 out of Canada, which showed that a family doctor, after similar training, 50 supervised ultrasound scans, had 100% sensitivity compared to radiology. And the other thing that they noted was that these exams in the family medicine clinic only took an additional 3.5 minutes to do. The way the scan is performed, the quick scan, involves screening the abdominal aorta from above the renal arteries down to the iliac bifurcation in the transverse and sagittal planes. Here's an image of the transverse plane. The aorta can be seen anterior to the spine shadow, and we're just following it down to the iliac bifurcation here. And that's the short axis. Then we would do the same thing in the long axis from the superior mesenteric artery just above the renal arteries down to the iliac bifurcation where the aorta can be seen as just tapering off. And I just show you these images here just to show you how simple it is and how quickly this can be done, again in under 4 minutes. And then the area of widest width would be measured, and anything that's greater than 3 centimeters would be considered abnormal or aneurysmal. And depending on the degree of widening, that would determine how soon that patient should be followed up. Anything greater than 5.5 centimeters would be an indication for referral to a specialist for repair because of the high risk for rupture. So again, the argument here would be that this is something that potentially we could be doing ourselves when the patient is already in the office to be sure that the screen is done and that there's a higher rate of adherence to the screening recommendations. Okay, next patient case is Mr. P. So this is a 40-year-old man who comes in complaining of unilateral leg swelling, and this was after a long plane trip from overseas. On exam, you notice that the right leg is 4 centimeters more in diameter and it has increased pitting edema, whereas the left leg looks normal. And he has no prior history of any problems like this. So you're concerned about a DVT, but say you're in a rural clinic or just any clinic where you don't have access to a vascular lab at nighttime. It's not an uncommon scenario. After hours or certain times of the week or day that's not available. And a lot of times the recommendation, if you talk to the radiologist or anyone about it, that it may be to anticoagulate the patient until the studies can be performed. So I think this is a potential area where point-of-care ultrasound could be very valuable as well, because it can give us an answer right away when our patients are there. And limited protocols for evaluation for DVT have been studied in the literature a lot. There's the 2-point compression ultrasound, which is really a 2-region exam, 2 areas in the proximal leg. And this has been shown to be sensitive and specific for lower extremity DVT when performed by specialists, such as radiologists and technicians, but also when done by non-specialists after limited training, such as ER physicians. And this can be found to be done in under 4 minutes, again, as opposed to the complete protocol, which takes longer, usually about a half an hour to 45 minutes to do. And there's lots of studies on this, including a systematic review that has found that in the emergency medicine literature, ER physicians can be very accurate with this compared to the radiology performed ultrasounds. This is one study that I just am showing because it included family medicine residents, and very interesting because in this study they did only 10 minutes of bedside training before assessing a convenience sample of 200 patients, but they found that after the 10 minutes of training, they were 100% sensitive and specific compared to the formal ultrasounds that were done. So again, this isn't one study to hang your hat on, but again, outside of the study, there is a lot of literature showing that this is effective, and also showing that used in combination with follow-up ultrasound, with D-dimer testing, or with a low pretest probability can be have a fairly high negative predictive value. So here's an example of sorry, it looks like one of my videos is not working here, but this is an example of what the protocol would entail. It involves looking at the common femoral vein and following it from the saphenous vein junction down to the bifurcation of the femoral vein. And in the normal vein, which is not showing up here, there should be compression of the vein with gentle pressure from the probe, whereas in this vein here, where there's a clot on the right side of the screen, the vein does not compress. And this would be repeated down in the second region, which is the popliteal vein, from above the crease of the knee down to where the popliteal vein divides into the calf veins. And here you can see the popliteal vein on top on the left image, and you can see with pressure it completely collapses. Whereas on this image on the right side of the screen, the popliteal vein does not collapse with pressure because there's a clot there. And this is just a diagram again showing how this can be utilized. The exam by itself probably doesn't have enough negative predictive value to completely rule out a clot, but if it's used in combination with either low pretest probability as determined by a Wells score or other validated score, or a negative D-dimer, or if the D-dimer is positive, a follow-up to two-region compression ultrasound exam in 7 to 10 days. And again, this is something that can be done quickly, under 4 minutes in the primary care provider's office. Okay, next patient is a 60-year-old female who comes in complaining of a new mass under her right jaw that she just noticed starting about a week ago. She does have a prior history of smoking and mild vascular dementia, and she's here with her cousin who brings her in today. She's also noticed a 15-pound weight loss over the 6 months, but has not had any other significant symptoms. So on physical exam, you do notice that she does have this lump underneath her right jaw, and you're not quite sure what it is. So you take out your ultrasound and do an evaluation. And this is what you see on the left side, this sort of circular dark area which you suspect is an abnormal lymph node. And for comparison, on the right side here is a normal appearing lymph node with a dark cortex in a hyperechoic white hilum. This one is longer than it is wide, whereas the abnormal one that we're seeing on our patient is more circular. And this lymph node, you notice, has several features of malignant lymph node and is concerning. So it's larger than 2 centimeters when you measure it out. And again, the length to width ratio is less than 2, so it's more circular than oblong. It has a somewhat heterogeneous texture, and it really doesn't have that hilum that we saw in the other lymph node, which are all concerning for malignant lymph node. So we can go ahead and use our ultrasound to do a guided fine needle aspiration of this concerning lymph node. And results come back as squamous cell carcinoma, which prompt you to then order a head CT, a CT of the head, neck, and it does confirm a mass concerning for nasopharyngeal carcinoma. And so not only were you able to determine that this patient's mass was concerning for a malignant node in the same visit that you saw her, but you were also able to use that to guide a fine needle aspiration and get a definitive diagnosis by the next time you saw the patient. And I think this is an example of how ultrasound can really help expedite the diagnosis of certain conditions. Okay, and the last example we're going to go through here, this is Mrs. Q, and she's a 35-year-old with right shoulder pain. And she's been complaining of this pain and in addition weakness, in her right shoulder for the prior week. It was triggered after she fell off a bicycle, sort of onto her shoulder in an awkward position. And when you examine her, you notice that her right shoulder has objective weakness and there are positive impingement signs of the supraspinatus. So what would be your next step for assessment? So I think very commonly in this situation, the MRI, maybe we get an X-ray, but a lot of times an MRI is the next go-to evaluation when we're concerned for rotator cuff tear. But the Society of Radiologists in Ultrasound came out with a consensus statement a few years ago, and they stated that ultrasound really should probably be used before MRI in most cases because the accuracy is really almost identical. Ultrasound is really just as good as the MRI, but it costs far less and patients like it better. It doesn't take as long to do and you don't have to lay inside a enclosed space like for an MRI. And ultrasound doesn't have contraindications. You know, even if patients have metal implants or pacemakers, they can still get it done. So here's an example of our patient. On the left side of the screen, this is the patient's normal shoulder, and we have a nice normal intact supraspinatus tendon. But on the side that she's symptomatic, you can see that there is a tear of the tendon with this black anechoic fluid interrupting this normal fibular structure of the tendon. And so if we apply this to a treatment algorithm as recommended by the American Academy of Orthopedic Surgeons, you know, this is a patient who is a potential surgical candidate. So she's less than 50 years old, doesn't have a lot of comorbidities, and does have a clear functional deficit from this injury, and it's an acute tear. So our ultrasound helps us determine that, yes, this patient does have a full thickness tear, and she should be referred to surgery. And the surgeons may want to get an MRI before they decide to operate or not, or what exact type of surgery they want. But in other instances, if this patient was found to have either no tear or only a partial thickness tear, you could use that at the bedside to really determine that this patient would be a candidate for non-operative surgery, should probably be referred for physical therapy, and would not need the MRI and not need the referral to surgery. And I think, you know, over time that this could potentially decrease the number of referrals and expensive tests that we're using for a very common concern, which is shoulder pain. Okay, so those are some of the applications. Again, those are just a few out of many, many applications in primary care. But I wanted to take some time at the end of the talk here to talk about the most common questions that I get regarding this, which are related to billing. You know, can we get reimbursed for doing this in primary care? And credentialing. Usually the question is, what do I have to do to be signed off to do this, to be credentialed to do this, to be certified? And I think it's really helpful to start off by just going through some of the vocabulary that we use when talking about these things. Accreditation, certification, and credentialing and privileging are 4 terms that get brought up a lot and tend to get used interchangeably, but really do mean different things. So I just wanted to start off by clarifying the meaning of each term. So accreditation is something that is done at the practice level by an external body. And an example of an accrediting association is the AIUM, who's sponsoring this webcast. The AIUM does have certain parameters for different practices that can get accreditation for different applications, such as obstetrical ultrasound or other uses of ultrasound. And accreditation usually involves showing that the providers who are providing the diagnostic services have a certain amount of training and usually continued medical education, and that they perform a certain number of ultrasounds each year. The same thing for the technicians. If there's technicians performing the ultrasounds as well, that they would have some sort of training proven. And then other things such as upkeep of the equipment and documentation and protocols. But the after a practice would apply for accreditation from the agency, and they would come and review that they meet the criteria and then receive that accreditation at the practice level. Certification is similar, but this is for the individual practitioner. It's from an outside body, but it has to do with a specific provider, not the practice. So, for example, the ARDMS was one of the most common certification bodies for medical sonography. The ARDMS originally, their main mission was certifying sonographers, but as more physicians started doing point-of-care ultrasound with the movement in emergency medicine, more physicians wanted to get certification as well to show that they've done the extra training. So the ARDMS has actually formed a parent company called Intelios now, which is split into the ARDMS and APCA. And the APCA now works specifically for certification of physicians. And usually certification will require that a physician has done some certain level of training, whether it be a CME class or a fellowship, and that they've performed a certain number of supervised ultrasound exams. And then once you attest that that has been completed, and you otherwise document that that level of training has been finished, then there's a examination that's taken, usually of knowledge, an examination testing knowledge to show that you have met that level of knowledge for the certification, and then a certification is granted by that agency. So accreditation and certification are completely independent and different from credentialing and privileging, which are usually used interchangeably. This is something where we're really talking at the hospital level, the practice level. Pretty much every hospital or large group practice will have a credentialing committee that will meet and decide what privileges every provider that works at that facility or in that practice, what procedures and what types of patient care they can provide. So in order to practice medicine in a state, you really only need the license to practice medicine from that state, and you can set up a private practice and perform whatever type of medical care you feel comfortable doing in your private practice. But of course, you'll be held to the standard of care of any specialist if there's ever a medical liability case brought up. So it's important that you only practice within your expertise. But credentialing, again, it's a little different, because if you want to go and practice in someone else's facility, in someone else's hospital or practice, then you need to get their permission to practice there, and that's where the credentialing and privileging process comes about. So a lot of times the question then comes up, in order to get credentialing, what do I need to do? And let me backtrack for a second. Accreditation and certification are not necessarily requirements for credentialing and privileging. The same thing for billing. For submitting bills to Medicare and Medicaid, there is no specific requirement for accreditation or certification at this time. Some private insurers may have some differences, and you'd have to check with your local insurers about the exact requirements for accreditation or certification. But for credentialing, so at the hospital level, what are the recommendations for the amount of training that a provider should have in order to perform point-of-care ultrasound? Well, again, this is an area where we I would like to thank our ER colleagues for having sort of set the standard here. In the American College of Emergency Physicians guidelines, which have been out for quite a while now, they outline two potential pathways for credentialing. One is the residency track, where you would get enough training in residency to have your program director give you recommendations that you have are competent to perform point-of-care ultrasound by the time you graduate, recommendations for privileging. And the other track would be for those who did not have the opportunity to complete this training in residency, and they would like to complete it during their practice. So this would involve several components. One will be doing a CME course, pertinent to the type of ultrasound that they would like to provide, and then performing a certain number of supervised scans. The recommendation is 25 for any individual exam, like a AAA screening. It may be less for image guidance. If you're doing ultrasound for guidance for procedure you're already performing, you may only need 10. Or there's also the option for global point-of-care ultrasound, which would be 150 to 200 ultrasound exams in different applications, and that would be the prerequisite for global ultrasound credentialing. And what counts as a supervised scan, there's basically three different ways that can be done. One is through directly supervised scan, so this would be somebody kind of standing over your shoulder and watching you perform the ultrasound. The other option would be images that are indirectly reviewed, so you can store images for someone to review and give you feedback, or upload through an online system or email, and have them indirectly reviewed and feedback received that way. Or the third option would be to perform your own individual scan and then compare that to a formal ultrasound scan. So if you were going to send somebody for an echo, and you did a bedside echo or looked at their IVC, and then you didn't use your exam for patient decision making, the patient gives you consent that it's for education only, and you let them know that you're still going to send them for the ultrasound, and they're okay with that. But then you would compare your results with the formal ultrasound, and then of course all of these should be logged in some way so that these can be shown to a credentialing committee later on for documentation that you have completed the requirements. And then of course it helps if you actually have a credentialed supervisor who can oversee this. So this would be somebody who's already had their credentialing through one of the pathways and can directly supervise you and then sign off in the end saying that you've completed this plan of supervision. But this is the recommendations from the American College of Emergency Physicians, and I can tell you that the American Academy of Family Physicians, in the curriculum guideline, which is coming out in several months, will basically match this verbiage for the most part. It'll be very similar recommendations. However, the American Academy of Family Physicians decided that that was best put in the curriculum guideline and is not going to come out with a separate document specifically on recommendations for credentialing. So for billing, as we were saying again, there's no specific requirement for accreditation or certification for Medicare or Medicaid. You just need to be a licensed physician or have a licensed physician supervising. However, there may be some differences from some private insurers, but at least in South Carolina, we haven't run to that specific requirement yet. There are requirements for documentation. There must be a separate report put into the patient's chart for any diagnostic ultrasound procedures. The report must include the indication, which must have some medical necessity. It can't be done for just any reason. There has to be a medically indicated reason to do the exam. There has to be a description of the exam that's being performed, limited or complete, and a list of findings, including any measurements that you perform, should be included in the report. And then finally, there should be an impression, which is your interpretation of the findings and recommendation for follow-up imaging or how to interpret them otherwise. And then there is a requirement for permanent image storage. So the ultrasound images need to be kept some way. There's no specific requirement about how, whether it's printed images that are stored somewhere in a patient's hard copy chart, or whether they're stored through a PACS system or as images pasted into an electronic medical record. Of course, it needs to be HIPAA compliant, but you, as long as you're able to pull up these images in some point and provide them for any legitimate reason, whether it's an insurance audit or the patient or another provider requesting the images. You just need to be able to reproduce them in some way. So the other interesting thing about the diagnostic CPT codes that's a little bit different from our typical CPT codes is that they're divided into a professional and a technical component. The professional component is traditionally what would be paid to the radiologist or the specialist who interprets the images and completes the report, whereas the technical component would go towards reimbursing for the equipment, the sonographer's time, and any of the other overhead costs. Now this is a little bit different. This doesn't fit the point-of-care ultrasound model too well, because a lot of the technical component is also being done by the professional in these instances when the physician is performing the job of the sonographer. So this is a list of the different, several different applications, including the CPT codes, and then the global fee, which is that overall total fee for the CPT code, and then the professional component, which typically it seems to be about 1/3 of the global fee. The professional component is denoted by a 2.6 modifier on the CPT code, whereas the technical component would be a TC modifier. The important thing to note here is that if you're in private practice or otherwise in a facility not part of a hospital, and you own the equipment and you perform the ultrasound, you can bill for the global fee. However, if you're in a hospital, if you're in an emergency room, if you're in the inpatient setting, or if you're in a hospital-owned or an outpatient clinic, which is part of a hospital, then the insurers will only pay the professional component, and the hospital itself would have to bill the technical component. So one of the other things I wanted to point out in this list here were the procedural codes for ultrasound guidance. These are a little different from the diagnostic codes because they include the procedure and the ultrasound together, and there's no professional and technical component here. There would be a separate facility fee for the hospital. For example, for arthrocentesis, large joint such as a knee, 20611 would reimburse $93 from Medicare, which is about $30 more than the unguided procedure. So going a little bit into what are the costs of the equipment, there's obviously a large spectrum of different equipment that could be used. A lot of point-of-care practices will use the laptop-sized ultrasound units. Depending on the number of probes that you want, that would depend on the number of different applications you plan on using it for. But these can run anywhere from $40,000 to $75,000 for a complete upfront purchase, depending on the manufacturer. And there's some newer manufacturers coming out now that are not the the top sellers, newer to the market, who are selling for even less than $40,000. But I think one of the things to consider here is that if you don't have the money up front, like from a grant from the or a large purchase from an institution, you should consider leasing. That's always another option. A lot of times the lease can be similar to financing with a very low interest rate over the course of 5 years or so. So similar unit would cost something around $600 to $1,250 per month instead of needing to pay the full price up front. Now, if you're looking at something like a pocket ultrasound, which would be a smaller ultrasound that can fit in the pocket of a white coat, usually they have one ultrasound probe, but they can perform a lot of the same applications as the bigger laptop units, and they tend to cost a lot less. So if you're looking at an ultrasound, pocket ultrasound, potentially that would be $5,000 to $10,000 up front. But if you wanted to lease that, maybe only $150 to $200 per month, depending on the exact make and model. And the other thing that's interesting to point out here is there's a special tax deduction, the Section 197 tax deduction, which states that if you're leasing medical equipment out over time, you can deduct the full upfront cost of that equipment the first year that you start leasing it. So if you were to lease that $10,000 pocket ultrasound over 5 years and pay $150 $150, $200 per month, you could deduct the full $10,000 from your business income taxes that first year initially, which would help with some of that upfront cost while you're first learning to use it and learning to bill for it. So last slide here, I'm just going to talk a little bit about a potential startup model that I think works for a lot of people who are already in primary care. I'd recommend leasing, like we were just talking about, the least expensive machine, and to use it to guide a procedure that you're already doing. So a lot of family doctors, for example, do knee injections or some other type of arthrocentesis. So lease a pocket ultrasound, use it to start billing for guided procedures that you're already doing. You should be able to do that after just practicing a few times. Get pretty comfortable with it because it's a procedure you're already doing. You're just adding on the ultrasound guidance. And then once you start doing that, you can increase the amount of reimbursement you're getting for those ultrasound procedures that you're doing. Potentially, you know, as we looked before from Medicare, up to $30 more per procedure. So if we're talking about a pocket ultrasound, which is only going to be a few $100s per month, you would only need to do 5 to 10 guided ultrasound procedures per month to cover the cost, and then anything else on top of that, you can start to learn to use other applications. And once you're comfortable, perhaps doing an IVC assessment for somebody with heart failure, once you're able to do that, you can start billing for that, and you can start to generate more income on top of what you need to just cover the cost of the equipment. And then as you go along and you increase your repertoire of applications that you're billing for, you may be able to upgrade to different equipment, which could then further expand your applications, potentially buying another ultrasound machine with more probes that would increase your capabilities. One thing that I did just want to add on to is that if you do plan on sending a patient for a formal ultrasound, regardless of your diagnostic ultrasound, that's really just considered an educational ultrasound, and you can't bill for that. But if you do perform your limited ultrasound and you find maybe that things are not normal and you think they need a complete formal ultrasound, then potentially that's someone that you could still bill for that, and then the specialist, when they see them, could bill for a complete ultrasound separately. Okay, so that is the end of my talk, and I'm going to look now. Looks like we have just a few minutes here to answer any questions that we have. Okay, so we have a question from Nick. It says, do you regularly use the 2.6 modifier when billing? Others in the ER community have advised against billing the technical component as you run into the conflict of interest laws, owning your own imaging facility and referring to yourself. Well, I'd say that, Nick, that's a great question. I, in my practice, only use the 2.6 modifier because I am in an outpatient clinic that is considered part of the hospital. We bill as a site of service under the hospital, and even though it's a separate building, it's still considered part of the hospital, and Medicare, Medicaid will not reimburse the technical component to us. That has to actually go through the hospital, who bills that separately. But what potentially can be done in those situations is that you can work out a deal with your facility, with your institution, because you are performing some of that sonographer work, which they are getting reimbursed through the technical component. So you could work out either a contract where they would then pay you back for each exam that you do for the amount of work done that would normally be reimbursing the sonographer, or you can use that in some other way to for your benefit, to negotiate with the facility. Maybe you could use that that knowledge that you're generating extra income for them to purchase more equipment for you, or to otherwise give you time to do ultrasounds or training in some other aspect. So good question. So next question by Alvin. Are you more likely to be audited by doing ultrasound procedures in clinic as opposed to blind? So I think that question refers to if you're doing ultrasound guided procedures, does that make it more likely that insurance would audit you to be sure you have all that documentation there? I don't think so. I can't say for sure. I think this is something that would be dependent on every individual insurer and their criteria for auditing. I think more likely audit's going to come if your documentation is incomplete, or a lot of times if the CPT codes do not show medical necessity. So you have to make sure you use this, not CPT code, sorry, the ICD-10 code. So you want to make sure that you use an ICD-10 code that really the insurance company has associated with being a reason for medical necessity for that procedure being performed. Next question from Daniel. Is billing for OB ultrasound different? Does it still use the 2.6 modifier? So yes, so billing for OB ultrasound is the same thing. It falls under that category of diagnostic ultrasound code. So yes, it would be the same thing as would have a 2.6 modifier for the professional component and a separate one for the technical component. I didn't put that in the list of codes there, but you can look up these codes too if you just Google the CPT codes for ultrasound. There's lots of good resources out there that can show you which are the correct codes to use. Question from Amy, can you bill for an ultrasound using the pocket ultrasound? So good question. Yeah, and absolutely you can. You can use any ultrasound device as long as you meet those requirements that we talked about before. You have to have medical necessity. You have to have a separate report that's put in the chart. So it can't be just written underneath the physical exam findings. There has to be an actual separate report, just like a procedure note. And you have to permanently store those images. So you have to have some way, some HIPAA compliant way to store those images and be able to pull them up if anyone ever requests the records, or if the insurance company audits you, you need to be able to reproduce them. So you can do that by storing it on a secure encrypted drive. You can store it. There's certain PACS programs, even smaller ones that you can that are fairly affordable even for a small private practice, where you can upload them through the cloud, or some people still will print out the thermal images or print them in some other way and store them in a hard chart, like a paper chart. Any of those ways are reasonable as long as you have the images and as long as you can reproduce them if you're ever asked to. Okay, so if we are renting versus leasing a machine, does the billing requirement change? That's a question from Arman. So basically, renting and leasing are pretty much the same thing, I think, as far as the billing goes. As long as you're paying for that machine and you're maintaining it, that is reimbursed under the technical component. Now again, if you have your own machine and you're using it in a hospital facility, like in the emergency room, you're not going to be able to bill that technical component. So that would be an instance where you'd have to work something out with the hospital. Either they're going to contract with you for you to bring your machine and use it, they're going to contract those services from you, or in some other way you'd have to, probably the best thing to do would be to ask them to provide that equipment in some way.
Okay. That's it. Thank you very much, Dr. Bornemann. And on behalf of UM and our thanks to all of you who participated in today's webinar. Please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. So long, everyone.